And so our second presentation today will be given by Dr. Susan Magasi, Shoma Webster, and Linda Cassady. Dr. Magasi is an associate professor of occupational therapy and disability studies at the University of Illinois at Chicago. Her research team, called the Program for Healthcare Justice for People with Disabilities, is committed to identifying and eliminating barriers to healthcare access, quality, and outcomes for people with disabilities. She uses a community-engaged participatory approach by partnering with people with disabilities in all phases of research process, from conceptualization through knowledge translation. Ms. Webster is an occupational therapist and clinical doctoral student at the University of Illinois at Chicago. Ms. Webster is working on a culturally relevant curriculum design to further address the mental health needs of Chicago's diverse population. And Ms. Cassady is a Chicago-based entrepreneur, artist, and graphic designer. She participated in the Knowledge Translation Collaborative as a community partner, sharing her professional expertise and experiential knowledge as a cancer survivor and a woman with a spinal cord injury. Their presentation today is Knowledge Translation Collaboratives, a novel curriculum model for building capacity in graduate students and consumers. And as a reminder, if you have questions during the presentation, please ask them in the chat box and we will address them as we can. Using questions from the chat box, I'll moderate a Q&A following their presentation. And with that, Dr. Magasi, are you ready to begin?
We are ready. So thank you for that nice introduction, and we're really happy to be here. We're going to be quite a change of pace from that last fantastic presentation, but we're excited to share our work about some training models that we've used to train both members of the disability community and graduate students in the principles and doing of knowledge translation. So we'll share our curriculum overview, and then we'll try to exemplify how it works using a single case example. So to lay the foundation for the work, I teach the Foundation Research Methods class here at UIC to our occupational therapy students, and we really try to emphasize the importance of evidence-based practice. But I realize that even teaching students those to be critical consumers of research and even how to conduct extensive literature reviews and synthesis does not in and of itself adequately prepare them to implement these changes at a clinical or a systems level, although they're in the midst of this course now, so don't share that information with them. So we recognize that it is increasingly important that evidence-based practice is really based on effective knowledge translation. And indeed, knowledge translation has been described as an essential capacity for 21st century practice in all healthcare disciplines. We think that it's important that KT be recognized as this shared responsibility, especially between clinical and research communities, but also the importance of having patient and consumers be part of that KT process. Unfortunately, knowledge translation isn't routinely taught as part of graduate education in health and medicine. So students and then ultimately practitioners are kind of left to their own devices to figure this out or come to this knowledge on their own. So to address this gap, we developed a graduate elective called Knowledge Translation for Disability and Rehabilitation Research. And at the heart of that, we use a model that we call KT Collaboratives that seeks to mirror real world practices, although admittedly in a very compressed time frame and sort of petri dish of the 15-week-long semester. So that brings us to the goals of today's presentation. We're going to describe to you the KT collaborative approach. Embedded throughout, we'll talk about some of the strengths and challenges of using this model to try to do real-world knowledge translation, or at least elements of it. And then we'll share this case study to show you how we've integrated existing KT frameworks and tried to put some of these elements in practice, both in terminal KT, but also integrated KT approaches. So I'm sure this model is familiar to many people on the group, but the graduate elective that we do tries to draw on a couple of theoretical frameworks for knowledge translation. So the first one that we use is the knowledge to action framework to help structure both the curriculum, and many of our weeks in the syllabus mirror steps in this action cycle. But it also provides students in the class with a framework to apply directly to their own work as students, in their coursework, in project and thesis work that they're doing, and then also if they're asked to implement new innovations and practices into their field work. So I'm sure that many of you are familiar with the KTA model, but in a nutshell, it consists of two parts. In the center, we have the knowledge creation funnel, and then around the perimeter is the action cycle. Now, most graduate research classes focus on the top of that knowledge funnel. So we expect students coming into the class to have that research foundation to be able to understand how research is done and conducted and evaluated for rigor. So in the KT class, what we focus on is the bottom of the funnel, creating knowledge process products, and then also understanding and applying elements around the action cycle. But even as we engage in understanding and applying the KTA framework, I think we're always reminded of this quote by Masuda and colleagues, which really challenges us to acknowledge issues of power and competing interests as we go about preparing to engage in KT work. So we use Masuda and colleagues' equity-focused knowledge translation framework throughout the course as a tool to start talking about and acknowledging power and power dynamics in knowledge translation. Now, as all of you I'm sure are well aware, talking about power is never easy. But what this framework does is by using a combination of critical inquiry and reflective practices, it provides us with a safe, proactive, but also slightly provocative forum to engage in this work and some frank discussions about power. It's particularly challenging, I find, for students who are just beginning to learn this knowledge and maybe have varying degrees of experience in the clinic about how power plays out. So we have all members complete this framework, and then we go back to it repeatedly, especially as the semester evolves and the work becomes more challenging and some of these competing interests start to emerge. So at the core of this graduate elective are what we call knowledge translation collaboratives. And what these are is that we bring together members of the disability community with graduate students as co-learners and co-creators of knowledge products to promote healthcare equity for people with disabilities. So it's important to recognize that the knowledge collaborative model is a little bit different than having members of the disability come in as periodic consultants or just to share their experience in a one and done kind of way. We have the members of the disability come in for the entire 15 weeks of the semesters as really integral team members. So this integration, we feel, is critical. Then what we do is we actually immerse in an active area of research or program development. So in addition to learning sort of the didactic or the science behind knowledge translation, we're also emerging in an active area of research. And when we select the members of the disability community to come in and partner, they're people who've got a strong vested interest in this area, either as people who experience the phenomenon being studied or having a strong advocacy interest in that area. We also use elements of experiential, learn by doing, and transformative learning. And the teams then work together to create these knowledge products, and then think through very carefully how the knowledge product can be implemented to support a larger KT initiative. We've done this by being able to leverage partial funding through a variety of grant mechanisms, some internal to our institution, but also with funding from PCORI and the National Cancer Institutes. So just like knowledge translation initiatives require the bringing together of diverse stakeholders, so does this class. So the KT collaboratives learn from and with a community of experts. And this has included over the years our local centers for independent living, policy experts, members of the clinical community, as well as a professional filmmaker who has really helped us develop some novel knowledge products over the years. And now Shoma will talk you through the next slide with some examples of the knowledge products we've created.
Thank you, Susan. The following are examples of knowledge products that KT collaboratives have created over the years. So the diversity of products reflects that different stakeholders have different preferences for how they use and consume information. We learned the importance of tailoring the message to each stakeholder. It is not only important to convey the information to stakeholders, but to also reinforce that action needs to be taken. This is demonstrated with the use of policy briefs, which synthesize the best available evidence to make recommendations for policymakers. Infographics are a useful method of visually displaying information and content. So students were able to design infographics based on the evidence and with input from members of the disability community to create a product that can be used to educate consumers. And later on, Linda will talk more about her role in the development of infographics. Educational videos were knowledge products based on a collaborative process between the graduate students, members of the disability community, and a professional filmmaker. The results were a product that is both evidence-informed and emotionally evocative, but also a way to drive that call to action piece. The filmmaker really challenged us to think about how we can use the power of film to get our message across. And lastly, students and disability partners were able to culminate their efforts at the end of the year into a poster to present at an academic conference. So the photo on the bottom right-hand corner was actually taken at a cancer research symposium earlier this year, where we informed conference attendees of the work that we were doing to increase the awareness of disparities that exist in higher education for students with disabilities and our role in using the knowledge to action framework to address the issues that we encountered. So here are my reflections. I'll let you take a moment to look at it briefly. So the knowledge products that we created in class were a great way to drive home the concepts that we learned. And there were quality products that we could use in the immediate future. And after completing the knowledge translation class that was taught by Dr. Magasi, I was able to apply what I had learned about the knowledge translation process and the knowledge to action cycle to facilitate a similar process in my own research. And as a result of working on the film in a more directive role, I acquired knowledge on the filming process and terminology, but also I learned about some of the ways that students with disabilities may encounter situations in higher education. And I ultimately hope that the film would be a starting ground to not only highlight the UIC CAN Research Fellowship that we'll talk a bit about later, but to also have it be a conversation starter for discussing these issues. Behind the scenes, it was clear how much a project like this meant to the end users.
Thanks, Shoma. So Linda, you participated with us as one of our consumer participants.
Yep.
And I was wondering if you could share how your expertise as a disabled woman and a cancer survivor added to the class the year that we were focusing on cancer screening disparities for women with disabilities.
Well, I was relatively extemporaneously going through the process of screening and then cancer treatment and whatnot when the class was going on. And one of the things that I never, just because I live in an urban area and have access to, a large hospital where my primary care happens, is the experience of just the literal accessibility to mammograms, which is what we were kind of focusing on in terms of that. I didn't realize until participating in the class just how much other members of the community, the disabled community, have screening issues in terms of whether they can actually get into a facility that does the screening, to working with techs that know how to work with you in the machine. There's just things that you wouldn't think about until you're confronted with the situation of, oh, how do you get a mammogram seated? Or how do you go through treatment seated? I'm not answering the question properly. Direct me, please, Susan, on how you would like me to add more to that.
Yeah, well, one of the things that I valued a lot about your participation in the class was your ability to be a good reality checker for us, to make sure that the students who, many of whom didn't have lived experiences of disability or going through cancer treatment, to be able to provide some guidance and ways that we could strengthen our product. So I was wondering if you had any thoughts on how you felt you were able to guide that process as well.
Well, like I said, from the learning, from being involved in just all the conversations, thinking of people that aren't in an urban center, such as, we're located in Chicago, smaller communities that perhaps don't even have a local facility that allows for people that are in wheelchairs to get, a mammogram in the first place. I hadn't even thought about that. So that was interesting for me because I come from a small town, to think of, wow, I wonder how people in that community would go through what I went through when I was lucky enough to just be able, as a consumer, with a little bit of direction with the techs at Northwestern, to go where you have to guide them in terms of how to treat you. And that's not an easy thing to figure out how to communicate, because everyone is kind of on new ground. So with the discussions that we had in class, for instance, I found those valuable in terms of what I could add from the, hey, this is what happened to me, in terms of either talking to a tech, or how do you position yourself, or guide someone to help you position yourself if that's what needs to happen, to when people in the class spoke up about various locations where maybe we have an embarrassment of riches in terms of facilities. One of the things that I learned and hopefully contributed to was just how many ways there are to have the dialogue with the various players, and then the benefits to approaching it X way versus Y way. So I learned from you guys, as well as being able to say, like, hey, when I dealt with this person this way, I felt, I feel like one of our other disability participants had issues when she experienced stuff that I hadn't, in terms of where she felt a little disempowered, I think, by the process, versus where I've always, when I've been involved in exams and stuff like that, like felt like a member of the team versus being talked to or at.
Yeah, and I think those experiences were really important when we were making decisions, especially for the video, about tone.
Yeah,
And
exactly.
wanting to make sure that we establish like a collaborative tone with our target audience versus an adversarial tone. So we actually spent several weeks of discussion about how do we sort of temper our outrage of what we were finding with some of the disabling barriers and attitudinal barriers in our focus group data, but then wanting to make sure that our video was well received by the people in whom we were trying to advocate for change.
Exactly. It's like you want to make sure it's a fine line to walk in terms of you want to empower the patient to ask questions and advocate for themselves, but then and have a discussion where often you feel like you can't, because that's such a power play when you're in the medical community. I apologize, my dog is barking. Where you're there almost like a pupil teacher dynamic, and that's not appropriate when it's your own health, to feel like you're being told what to do in a way that's not respectful. Versus we want to make sure that when we're talking to the caregivers and the providers that, hey, there's benefit to making changes to how you deal with people, because there's going to be good outcomes across the board for everybody involved. You're going to get a better exam and someone that's going to actually tell you the various things that they deal with, whether it's pain or finding a lump or whatever the case may be, so you feel comfortable speaking to the provider, and then the provider feels like, oh, there's benefit and reward to them putting the effort forth to communicate in a way that allows for that kind of thing to happen.
Cool. So now one of the things, when I first invited you to participate in the class, I knew about your disability experience and a little bit about your cancer experience, but what I didn't know was your professional background as a graphic designer and a set stylist. And I was wondering if you could say a little bit about how you think these strengths or skills of yours emerged over time and contributed to student learning.
Well, the one area for the video, the set building, or the set design background helped just in terms of like approach, more of a tactical kind of situation. So I think I was useful there as a, hey, how about this? Or we don't want to see that. But where I found I made a possibly even more valuable difference or contribution was when I was working with the students on the infographics, and which we're seeing a couple slides ago on the upper right hand corner. But it was great to kind of get them to think outside the box in terms of and learn, like we were all learning the stats and things together based on information that they had culled. But it was really fun for me to see them expand their horizons in terms of, hey, how can we really demonstrate this in a way that's visually engaging? And then, versus just bullet points. We're trying to, so it engages the viewer to read more. And they really got into it once they felt allowed to get a little creative. In terms of, I think one of our charts, we had a pie chart that we had that was a boob or the loudspeaker and things like that. Like, I think they got a kick of trying to figure out how to take their data. Like, that collaboration was fun. How to turn your data into something that's visually engaging as well as really valuable and interesting information just from a didactic standpoint.
Thank you. And I think, again, this is one of those things that if we had only had Linda come in as a collaborator, the disability/cancer expert, the students would have had a very different level of engagement. And I think what this model of KT Collaboratives allows the team to do is really work together and see people for their sort of full range of scopes and abilities and potential contributions. And it's not all roses and sunshine. Some of what they learn as well is that tensions emerge and that these competing interests do come into play, but it's a safe environment to allow those issues to play out. So thanks, Linda. What we're gonna do now is shift over to a case study from last semester's KT Collaborative, and how the work that they did fit into a larger KT-informed initiative where we were trying to create a cancer research fellowship for undergraduate students with disabilities. And that's called the CAN Research Fellowship. So we used, again, the KTA model to sort of guide the class and the work. But our first issue came up when we identified a problem or really an opportunity. My collaborator, David Chung, who used to be a program officer at the National Cancer Institute and is now here at UIC, recognized that there are these pipeline programs for underrepresented students, and they exist in 3 categories: racial and ethnic minorities, people who experience disadvantages like low socioeconomic status, and category 3 was disability or people with disabilities. And he noticed that very few programs, if any, were applying for that category C, people with disabilities opportunity. So we found that was a unique opportunity to create a program, but also introduced many implementation barriers, not the least of which is inertia. And if it's such a great idea, why hasn't it been done before? So we had to overcome that. So we started out with a team of 2. We had this lone visionary in the Cancer Center who didn't know a lot about disability and the disability experience. And then he partnered with me as an academic researcher who understands and is passionate about capacity building within disability, but maybe didn't have the connections and infrastructure to create a fellowship within the Cancer Center. So what we did is we saw an opportunity to use this existing framework of the KT Collaborative to help us build that infrastructure and bring in stakeholders who could help support and launch this fellowship. And this is the group of the KT Collaborative from last year's class. So we started with our KT Collaborative, and we recognized that there was this diverse group of stakeholders who we needed to bring in the fold to make sure the project or the program could launch. We needed funders, because we did this with private funding initially. We needed to get buy-in from administration. And then we also wanted to make sure that we had a strong set of mentors and guides who could really support development amongst our fellows. And our goal was to bring them all together. So then what we did is we expanded from having identified this problem and opportunity to go back to the existing literature to try to understand what really are best practices in evidence-informed pipeline programs that mentor different underrepresented students. How can we make sure that we're meeting the unique needs of students with disabilities? So why aren't students with disabilities participating as cancer researchers, for example? And then also, how can we use this to support future funding? So next, Shoma is actually going to guide you the work that they did as the KT Collaborative to support this work.
Thank you, Susan. So in the knowledge synthesis phase, the KT Collaborative conducted a rapid literature review to identify key challenges to participation in research for students with disabilities. What we found was that there were negative attitudes towards disability in higher education. There was also a lack of knowledge about disability and potential accommodations that faculty members could provide to those students. In addition, there was limited access to disability-related supports and accommodations. There were lack of role models with disabilities in research. There are also low expectations of students with disabilities, and we also found that those students had limited exposure to those core prerequisite classes. So what next? The collaborative then used this information to create knowledge products. So here you can see the infographic that was created. As you can see, there's information that 11 to 15% of students in higher education identify as having a disability. Sure, there are federal laws that support inclusion for people with disabilities in education, such as the Higher Education Opportunities Act, Americans with Disability Act, and Section 504 of the Rehabilitation Act. However, we found that students with disabilities were still underrepresented in the science, technology, engineering, and mathematics, or STEM fields, including cancer research. So pipeline programs are crucial to help increase the diversity and reduce disparities that is shown in higher education. They help to increase academic success and to reduce those barriers. These are just some of the reasons why the UCAN Fellowship, UCAN Research Fellowship was created. And the UIC CAN Research Fellowship also became the first pipeline program for students with disabilities. As you can see here, this is the second knowledge product that the collaborative created. We wanted to capture the raw emotions, the challenges, and the reality that some people with disabilities experience in higher education, and why we need pipeline programs like the CAN Research Fellowship. So please sit back, relax, and enjoy our short film.
Yes, come in, please.
Hi, Mr. Cooper.
Hi, Alexa.
I just saw this flyer about a cancer research fellowship, and I was thinking of applying.
Alexa, I know you're a good student, but this is cancer research. Let's make an appointment next week and find something that fits better for you.
Don't listen to that advisor. We all know you have what it takes.
I know, but nobody ever gives me a chance to prove it.
You should still apply to that fellowship.
We have two candidates equally qualified for this fellowship.
I've had a look at both of their resumes. I really like this one, but we've never had a student with disabilities in this lab before.
We do have a disability resource center on campus.
That's a good point. I hadn't really thought about that. Okay, I think I made my decision.
Hey, would you look at this? I think I'm onto something.
Oh, wow, that looks promising. We should write it up. I think we might even get published.
Alexa, can I talk to you for a second? Just wanted to be candid with you. I was a little skeptical at first bringing you into the lab, but you've made some very solid contributions, very important contributions to the team. I'd be more than happy to write you a letter of recommendation for grad school.
Thank you so much.
Hey, you're welcome. What are you working on over here?
Well, this is a sample of...
Congratulations, Alexa. Awesome job.
Congratulations, Alexa. What's next?
I'm going to grad school to continue my cancer research training.
I knew you could do it.
I knew I could do the work. Someone just needed to give me the opportunity.
Yeah.
The University of Illinois at Chicago's Cancer Research Fellowship is the first pipeline program to support students with disabilities. By bringing together top cancer and disability researchers and educators, the University of Illinois Cancer Center is uniquely positioned to make this program a reality. We need your support as mentors, partners, and future employers. Together, by focusing on abilities and not limitations, we can create a pathway to careers in cancer research and healthcare for students with disabilities.
We hope that you enjoyed that short film, and it was a blast to work on that project earlier this year. So after the film was completed, the CAN Research Fellowship developers then used the videos to support both fundraising efforts and to get buy-in from potential mentors and diverse stakeholders within the Cancer Center and the university. Now, Dr. Magasi will discuss how we adapted the knowledge into the local context.
Thanks, Shoma. That was a nice job. Yes, so as the KT Collaborative was working to develop the video, we were working in parallel to further create and refine the fellowship itself based on some of the work that the KT Collaborative did. So what we did is we took that information that we learned about best practices in pipeline programs, mentoring programs, as well as the unique needs of the fellowship, of students with disabilities, to create the core values and the core principles of the fellowship. So we organized it around the pillars of immersive exposure to both biomedical and social science cancer research. We recognize the importance of career development for undergraduate students. So this included leadership training, career exploration, and also tailored content about how to negotiate issues of access, accessibility, and accommodations within both a university context as a student, but then also thinking long-term of what would that be to be a career scientist. And then mentoring and role modeling from both high-level cancer researchers, but also people with disabilities who are doing research or doing healthcare delivery. We also were able to create field experiences that put the students and fellows in the room with people like the leadership team at Walgreens. We had a group of medical directors from a pharma company who sat down with our fellows for lunch. And these were just opportunities that these undergrads with disabilities who had experienced a lot of the barriers that Shoma talked about had just never felt like they would ever have a seat at that table. So those were some ways that we were able to build a curriculum that acknowledged best practices. But we still had barriers to implementation, and we worked on sort of identifying those and tackling them. And we identified these barriers both through the literature, but also as we were working to develop the fellowship and get buy-in from stakeholders, different kind of implementation barriers presented themselves. So the next slide shows some of the strategies that we used to identify some of the barriers. So we recognized all of those barriers that students with disabilities faced, but we also experienced some roadblocks from administration, particularly about the skepticism of the value of such a program and whether there was actually a kind of a target audience of quality qualified students. So we implemented a few strategies, including building this interdisciplinary team of collaborators on campus who would participate in creating and supporting the program. So not just the education and the research team, but also experts in the Disability Resource Center who could inform on providing accommodation. We created a training for mentors to address fears and concerns that they might have about working with students with disabilities in their labs. We handpicked those mentors who then served as champions for the program within the Cancer Center, but within their own labs. We tried to do our own funding, which neutralized some of the concerns addressed by administration that we were placing a financial burden on the Cancer Center. And then we also just engaged in continual feedback with our mentors, with our students, to foster this sense of community and buy-in and make them feel like they were part of something interesting and important. So this is a picture at the bottom of some of our fellows meeting with cancer survivors and researchers. So once we were able to raise the money and recruit the mentors for our program, it took a long time and delayed advertising and recruitment, but in spite of only having a 2-week recruitment period that overlapped with finals here at the university, we were able to receive competitive applications from 13 qualified students who we screened for eligibility and appropriateness. We interviewed 9 of them and ultimately welcomed 4 into the program, all of whom completed the 6-week fellowship. Then throughout the fellowship itself, we maintained this kind of close contact to make sure accessibility and accommodation needs were met. We received and used qualitative feedback from both the fellows and the mentors to strengthen the program and to make sure it was well tailored to the needs and expectations of the fellows and the mentors, and made those real-time adjustments. And then we continued the disability training throughout to ensure access. We evaluated both the process of implementing the fellowship in the doing of the fellowship, and then also are in the process of documenting both short and long-term outcomes for this cohort of students. This is the phase that we're in now, and after Dr. Moore's wonderful presentation, I think we can be even more strategic in our sustainability plan. But the goals now are to figure out how to sustain and scale up the intervention. And last slide, just in conclusion, what we hope you walk away with from this presentation with is a recognition of the value of a KT collaborative approach to teaching and learning about knowledge translation. The way that the KT collaborative model can be implemented in synergy with both terminal KT and ongoing integrated initiatives. Both students and consumers bring valuable energy and creativity to the process, but planning and implementing this kind of thing has to be done with a lot of intentionality and a strong attention to group dynamics. So that's all of our slides. I'll put it on mute and turn it over to Donna to facilitate the discussion.
Thank you so much, Susan and Shoma and Linda. That was fantastic, and the video was great. At this time, I would like to invite all 3 of you to turn your webcams on, as well as our reactors, Rosamine Ismail, Mary Goldberg, and Megan Tracy, and we will get going into a moderated discussion. I want to remind folks that we are taking questions in the chat box, so you still have time to ask some questions. Please put them there, and we'll make sure that we're able to answer them during this time. And so our first question actually comes from Mary Goldberg, and this is for either Susan or Shoma. And so Mary Goldberg raised the issue of how best to recruit consumer participants. And I was wondering if either of you could talk a bit more about that.
Yes.
And again,
sorry, I'm having trouble turning on my camera, but my microphone is working. This is Susan. So the way we have recruited the consumer participants is through our fairly extensive network of community collaborators here in the disability community in Chicago. So all of my research, as Donna mentioned at the very beginning, is done using community-based participatory approaches. So members of the disability community are partners throughout the process. So that gives us a fairly large network that we recruit from. And we do also just sort of word of mouth and some sort of snowball sampling approaches to find the right people to bring into the class, because it is a big commitment. And one of the things that we've noticed over the years, and this is a little different from your question, but that a lot of our sort of strong advocates in the disability community are used to coming in and doing the one disability lecture where they participate as sort of the expert on the disability experience. And what this process, it challenges the consumers to also engage a little bit differently as collaborators and engage in some of the give and take and negotiating out some of those tensions that come from bringing together people who are honestly, in the course with a shared commitment to justice often, but maybe some are coming at it because they're passionate about advocacy. Some of the students are coming at it because they want a good grade. They want to get certain learning. So that's some of the also challenges of figuring out the right people who can participate and commit at that level.
Thank you. And this next question, I'm going to turn over to Mega and Tracy. In what ways have you integrated consumers into the KT process?
Hi, thanks for the opportunity. A lot of this presentation resonated with work that we were charged with years ago with the Right to Know campaign that was developed using participatory approach with partners and Dr. Joanne Theory at the Centers for Disease Control and Prevention. We were one of the states that was funded to implement this campaign to increase awareness among women with physical disabilities of the importance of early detection screening for breast cancer. And again, we were just really positioned through previous activities that we conduct with our Centers for Independent Living and with People First, which is an advocacy group with chapters across Montana and in other communities across the country, and with developmental disability providers to just start with, here's the intervention, and really see what adaptations would need to be made locally before we implemented it. And really looking at the context in which we would be delivering it. And so we were able to do some pretty multi-level things with direction from our consumer base in that program, including accessibility assessments of all the mammography centers in the state, so that we could clearly message that every one of them had a mammography machine that lowered to a seated position, but we had to make sure consumers knew to ask, and we had to increase awareness of the centers that this was an asset they had to promote when scheduling screening appointments and diagnostic follow-ups. And we were able to also collect some of those initial data like we heard about, what are the major barriers that are real and being experienced, so that I think from our position, that tension, being able to acknowledge it, was very important, because I think that people involved in cancer did not want to believe they were overlooking this population. And so initially some of the feedback we got was that these screenings aren't for everybody. People who are very old, for example, would not necessarily want to participate in mammography screening anymore, meaning women over 90. And we had to, we had very real data and stories from local consumers at our Centers for Independent Living and in our People First chapters to say, well, that's not who we're talking about. And that was, so we had a variety of focus groups or listening sessions across the state where we collected those stories, and we did an electronic survey for those who couldn't participate on site in those opportunities. And we organized those into a report and share that with our partners. And And then we looked, we organized Plan Pink steering committees statewide, and were able to get input from consumers on what they thought about the campaign materials from Atlanta. And even though they saw some of our national leaders reflected in those campaign materials, including Judy Rogers and June Kales, they still wanted to see themselves. And so we created a multimedia exhibit with 12 women with physical disabilities from across the state who had all had breast health concerns. And we created very similar materials where they were telling their stories locally, and we rolled those out with our materials from CDC. And so we had a lot of buy-in from our consumers throughout the adoption of that campaign locally. And I think that led to the partnerships that have been sustained with our Cancer Coalition and the healthcare providers who actively participate in that coalition. I should add that having a disability advisor in the steering committee for the coalition is a major policy change that happened as a part of this process and is important to the sustainability. That's just one example that comes to mind and resonates here. I will say within APHA in the disability section, which I chair, a student just let me know she was interested in leadership opportunities, and I began conversations with her about what that would look like, and she said she'd like to see a mentoring program within the section. And so we had the opportunity to recruit Dr. Michael McKee, to be our mentoring chair to the executive committee, and to work with the student Meredith Williams to develop a mentoring program, which we're really lucky to be working with the National Disability Mentoring Coalition to shape, and we're launching it this year at APHA on Sunday. So I think that creating intentionally student co-chair positions in that committee helps us to be innovative, and really making sure that we're talking with students about, and students with disabilities about what is needed in the section and within the public health workforce is really important, and responding and helping to build the collaborations across sectors who are working on these cross disability challenges, barriers, and creating opportunities.
Well, thank you. And that's very exciting that you'll be launching this weekend. I hope it goes well. Congratulations. And so this next question actually comes from Rosamine, who's one of our reactors. And the question is for any of the presenters. And so the question is this: great application to the KTA model. I may have missed this, but did you incorporate the consolidated framework for implementation research or theoretical domains frameworks to identify and assess barriers and facilitators? And so,
we did not specifically, no.
Okay. Okay, and then another question. This one is actually for you, Susan, and the question is from Mary Goldberg. Could your researcher partners pay the interns stipends as a way to sustain the program?
Yeah, that's our goal, is that, and actually that's the NCI model for these pipeline programs, so that it's not just a 6-week-long immersion, but there are actually wraparound mentoring services. We know it's not, it's often not enough to get excited and immersed in research for 6 weeks, but true career development and the true fostering of that pipeline requires a greater sustained investment in these fellows. So our capstone event for the fellows was actually what we call Dolphin Tank, which was our sort of kinder, gentler version of a Shark Tank, where the students kind of pitched themselves as the product. So here are the sort of knowledge, skills, and strengths that I gained through this fellowship. Here are my long-term career goals. And then how could they use the opportunity to have this sort of cohort of mentors and leaders be a sounding board and a network for them to sort of make the quote unquote big ask and help them move on to whatever the next step was. So whether it's being a research assistant paid position with one of the actual mentors, or in some cases, the mentors fostered introduction to other people within their extended networks who better aligned with the fellows' interests.
Great, well, thank you. And so this next question, I'm going to turn to Mary Goldberg, and the question is this. The equity-focused KT framework recommends critical self-inquiry, including recognizing one's own exclusionary practices. How have you engaged in critical self-inquiry in the context of your work? And what are some challenges and benefits of this reflective practice?
Boy, this is a heavy question. I think so I'm a faculty member at the University of Pittsburgh, and I think our annual review process, performance review process, encourages this type of reflective practice. So certainly in my teaching, but also our programming, and I think it comes back to the connections that we make with our students on the teaching side and our advisees to help guide us on how we can be better leaders. And on the research side, I think if you're not in touch with your stakeholders from the beginning, even at the concept stage, there's real danger to barriers to ultimate adoption or implementation of your work. So I think the nature of our positions requires us to do this relatively frequently. Can you rephrase or remind me the second part of your question?
Sure, of course. And so the second part was, what are some challenges and benefits of this process? Like you said, it's pretty heavy.
I mean, I think challenges are that we all have unconscious biases, perhaps towards working with a particular group. And so I think understanding what we might be overlooking by asking ourselves those tough questions is a process probably that I should engage in a lot more, and a lot more than just annually. But benefits to that, I think certainly expanding your reach for whom your work can benefit, and also I think the likelihood of obtaining additional grants and additional funding if you're true to yourself and making sure that your work is not biased in that way, can help in that process. It's a hard question. Thank you for asking.
No problem. And so with that, I want to thank again all of our presenters and our discussants for participating in the discussion. Thank you so much.